Good afternoon, everyone. Thank you for joining us today. Today, we are joined by Lindsay with Stroudwater. This is wrapping up our fourth in our series of swing bed webinars for this grant year. And so Lindsay will be presenting. We are a smaller group today, so if you have any questions or concerns, please feel free to unmute your line or put something in the chat. Also, if you're watching this recording, if you have any questions at all, please feel free to reach out. With that said, Lindsay, I'll turn it over to you.
Great. Thanks, Laura, and good afternoon, everyone. Thanks for joining. This is, as Laura mentioned, our fourth webinar for the year for this Flex grant. So happy to talk a little bit more about swing beds. So today, for what we're going to really talk about, I'm going to refer to this quite frequently, and I think in the description for the webinar is really it actually spoke to what I'm going to talk about today is around uh, trying to figure out which are the most appropriate patients for your swing bed program. And what we call that is we call that a care spectrum. Similar, and that's what we're talking about, some strategies on how we can develop and kind of look at that, define what that process looks like, and how we as an organization can define what our care spectrum is for our swing bed patients. And so basically it's twofold. A care spectrum is defining who can be cared for at your facility based on kind of certain diagnosis or clinical indicators, and that they're the most appropriate patients for your swing bed program. Then on the reverse, it's also understanding who cannot be appropriately cared for at our facility. Those are the patients that we do not accept into our swing bed program. Maybe we have a patient that needs is a fresh trach or needs mechanical ventilation, and we do not provide that. And so what we're going to do is we're going to try to define that. We're going to develop our almost like an admission framework or a clinical framework for our swing bed program. All of that work is really based on what we can do as an organization. So doing some self-assessment around staffing competencies, provider availability, various ancillary services that we have access to, and what that means to our organization and who we accept or don't accept into our program. And we have certainly found out that many hospitals do not go through this type of formal process of really kind of defining that. And that's, we've really felt that way during COVID. Oh, if we can just make sure we just stay on mute, that'd be great. And we found that when we heard from a lot of hospitals that during COVID, more so on the acute side, where we could not transfer patients out. And so you were admitting patients because you had to, and those had typically been a patient that you would maybe historically transferred out of your organization. But we needed to keep those folks in-house because they had nowhere to go. We could not find them beds anywhere. So then hospitals started to, self-reflect and say, we can care for this patient. Although we had to historically transfer them, we can safely and adequately care for this patient in-house. And so hospitals, kind of self-reflecting and self-assessing whether or not they could, keep some of their maybe higher acuity patients, if maybe they felt like maybe they needed some additional nursing education to be able to continue to support these, maybe higher acuity patients more long-term and not just during the crux of COVID. So, we are starting to have these conversations about kind of expanding the care spectrum, your hospital's care spectrum. It's always going to be a little bit different for each organization. So it's really around a self-assessing what you can and what you can't keep into your organization. And this care spectrum can really be applicable to swing bed patients, which we're going to talk about today, but also you can also start to think about it for your acute patients or ICU or observation and at different levels of care and defining what that looks like. So why is the care spectrum important? Well, certainly we are seeing, and I'm going to share a chart with you in just a minute about some updated trends around rural hospital closures, something that continues to climb that we're seeing across the US. And we are also continuing to having staffing recruitment, hiring, retention, still is a challenge for our organizations. We have a reduced staffing, we've reduced bed capacity, so there's lots of impact on just the viability long term for some of our rural hospitals. And so, with a care spectrum, when you think about it, it's really about kind of identifying who you can keep, and hopefully with that identification in that formal framework that is then going to be clearly defined, it can really help lead to some improvement in our admissions, whether that is to um, acute or to into our swing bed program. um, the care spectrum also kind of improves on different procedures and workflows around efficiencies within the admission process. We'll talk a little bit about that. Certainly decreases variability in the clinical decision making. You may be thinking about, how we may have providers that on a Monday they'll accept this type of patient all the time, but maybe on a Friday they don't accept that patient. Same type of patient, just happens to be the day that they. And so again, having some formalized framework will help reduce some of that variability in decision making. To kind of go back to patient and staff satisfaction is really important as it relates to the care spectrum. And certainly, given that there's a contribution to the growth of our census, we see also an impact to our inpatient revenue. As I mentioned before, rural hospital closures continue to decline. We've had, since the middle of August this month, 153 closed or converted rural hospitals. Converted being that a rural hospital transitioned to a rural emergency hospital. And so we certainly see some of those numbers. In your state, it's to date, we've had about 8 rural hospital closures. And again, they could be critical access hospitals or PPS hospitals. But again, this is a trend that we do not want to continue seeing. So what we thinking about different ways that we can capture additional volume, whether to our hospitals, is really going to be the key as we continue to move throughout the next years and to come. And when we think about, and I've shared this chart quite a bit, I feel like it ends up in all of my swing bed presentations, but it really highlights what I say is the opportunity around growing swing bed census. And any of the hospitals, critical access hospitals that are in that yellow, there is hospitals that are not meeting their target ADC based on a service area population. And so I look at that and I say, well, there's certainly opportunity out there to continue to grow. You haven't met your target. You haven't tapped out that you can't bring in any additional swing bed patients. And so there's tremendous opportunity to continue to focus on growth of swing bed programs. So anything that we can do, whether it is further defining that spectrum of care, or it is, doing marketing and promotion of our swing bed program, there are still activities that we can be doing to continue to build and grow our volume for our swing bed programs. We were working in a few different other states where they've experienced such a surge in their acute volume. And so they've actually had to limit the number of swing bed patients that they can accept into their program because of the high surge in numbers on the acute side, not because of COVID, and it's really continued in certain markets. So, but without that being said, certainly swing bed continues to be such a growth opportunity for our rural hospitals. So when we're thinking about the care spectrum and really kind of developing it, what we want to see, certain outcomes or that would come out of developing a care spectrum is around kind of that streamlined process. And I mentioned that, whether that is on the referral decision. So if we have defined who we accept or don't accept into our swing bed program, that referral decision-making process becomes much more efficient because we've developed our criteria or our framework. And for a process that might take a couple of days to get back to your referral sources, I hope that's not taking a couple days. We would rather see, 4 hours or less. Typically, our rural hospitals report, in a day's time, 24 hours or so, we get back to our referral sources on that decision of whether to accept or not accept. But if we can reduce that time, what does that really it lends itself to some happy referral sources, right? If we can really kind of make that decision, we're efficient in our decision making process for that referral, it really helps on that referral source. So also on the patient throughput, getting that admission process too is a really streamlined process once we've defined that spectrum of care and who we keep. Certainly a outcome is around increased admissions. Also clinical expansion of clinical competencies. As I mentioned before, maybe if we have found that we want to kind of pursue our wound care patients within our swing bed, and maybe we just need some additional competencies and education for our nurse staff or providers around wound care. But since if we are invest in that and we make that a priority, then that can really kind of impact the admissions on the other side. And we're able to maybe accept more complex wounds, for instance, if we have that expansion of our clinical competencies. Reduce cost and opportunity cost, but also most importantly, improved value. Where appropriate patient care services are being delivered, we are providing care in the most appropriate care setting, because we're not just going to take anybody and everybody if we cannot adequately care for that patient and have those successful outcomes on the backside. And then the facility receiving certainly payments for services rendered. And then lastly, around the incremental volume. As we continue to increase our volume of our swing bed program, there is that, given that we are critical access hospitals and cost-based reimbursement, that benefit, that contribution margin of increasing our ADC or average daily census for our swing beds. This is just a snapshot of a financial analysis looking at increasing the swing bed days for a critical access hospital, and that contribution margin improvement of $192,000 for an increase of about 2.3 ADC for this particular, or 3.3, excuse me, trying to do math on the fly. It's not that easy. Again, so there is that kind of that benefit there from the financial perspective of really having that care spectrum developed from an operations efficiency standpoint, from a patient satisfier, from a reduced variability, and also the financial impact to our organization. But with everything, we know that we certainly have barriers that exist in our organization that may impact the ability to move forward and develop a care spectrum or this patient framework for our swing bed program. Some of the things that we have heard is this is the way we've always done it mentality. We've only accepted this type of patient to our swing bed, or we've always done, and I'm sure you've heard this in your own organizations, and or we have the what if scenario. Maybe we're making the decision to accept or not accept, but we're reacting on the what ifs. What if this patient declines? What if, and so encountering that over and over and over, certainly can impact your admissions into your swing bed programs. But if we do have those scenarios, and have we ever kind of dug a little bit deeper? Have we said to ourselves, yeah, we're not going to accept this patient, but do we have the complete picture of that patient? Have we received all the notes? Do we need to request additional notes or have a peer-to-peer to really get that level of understanding of that particular patient in the whole picture, and not just rely on those what if scenarios, which we hear happens at times. Are we missing opportunities for admissions? Do we hear from our staff sometimes that they're just nursing home patients? I know I've encountered that sometimes when I'm working with rehab staff, and I would hear that I didn't sign up to work in a nursing home, or and so again, those are kind of barriers and perceptions, but not having maybe an understanding of what we can be doing for our patients in a swing bed program. And then, so if we are able to define what we can do at our organization through this process that we're going to walk through in just a moment, does that help reduce some of those barriers? Does it help articulate the competencies, the expertise that we have internally to be able to accept or not accept a certain type of patient? And then, with anything, and we're going to really walk through the importance of having a team, but definitely there are going to be different barriers for different folks, whether you have medical staff barriers around, or barriers around communication. Maybe you have an organization that's very siloed. Having a siloed organization certainly can impact the communication, the efficiencies around your swing bed program, for instance. It could be lack of or reduced clinical competencies, or not an expanded clinical competencies. Maybe equipment that also is a barrier to certain types of admissions into your swing bed program. So I'm sure you all can self-assess and really reflect also on maybe some barriers that may come up that has prevented you from really building out and growing and having a robust swing bed program. So what are some of the key steps to create a care spectrum? And we're going to walk through a bunch of those, and then also provide you with an example of a organization that really kind of started to apply. They didn't have a swing bed program, but use this similar process to understand if they could or cannot open up or start a swing bed program, and what types of patients would be appropriate for their program based on their organization. So certainly it's very helpful to have a good understanding about your patient population and service area. Understanding, again, I talked about the opportunity. I think there's a good having a level understanding about swing bed services and skilled care utilization and estimates for your service area. So whether that is utilizing trends, looking at market share, looking at your population and a different demographic trend analysis. Is the population growing? Is our payer mix? What does that look like as we think about our potential for growth within our swing bed programs? And, some folks like to do some mapping, looking at like almost a competitor analysis, and being able to compare your program to others. This particular hospital was in Arizona, and then we mapped out, all of the different skilled nursing facilities that were around this hospital. Because you know what, they were sending out their patients for skilled services, And they, because again, this is the hospital that did not have a swing bed program. But then, so where are their patients going for skilled care? And what are those patient types? What are they going out for skilled services for? Is really important. And so, interestingly, we looked at geographically a few of the skilled nursing facilities around this particular hospital, or where the majority of their skilled services were going. And you can see, publicly available Medicare claims data can show the different diagnosis for skilled nursing facilities, particular to this hospital's referrals. Aftercare for fracture, whether it's hip, arm, leg. There was diabetes or cellulitis, infection, UTI, pneumonia, osteomyelitis, all very all diagnoses for skilled services that this hospital could have captured if they had a swing bed program. This similar, if you have and are operating a swing bed program, very similar, to reflect on that, to say, what, is there an opportunity to understand what else we could be doing, or expand our skilled services to capture some of those additional swing bed patients based on a diagnosis, or skilled care services. So after kind of a self-assessing the population, the market, it really comes down to that interdisciplinary swing bed team. And likely one for your organization already exists. I think it's a huge component of a successful swing bed program, is to having that IDT swing bed team, and comprising of nursing, pharmacy, providers, rehab, supplies, and business office. And each one of these kind of core team members play a role in developing that care spectrum. And we'll walk through some of the key areas here and what they can bring to the table as it relates to that care spectrum development. For nursing, having a good understanding around your nursing competencies. Do we have those special licensures or certificates of any of our team? I brought up wound care. I have to say, in one state where there's a lot of traction around certifying nurses, there are wound care certified nursing programs and certificates out there right now that are being pushed by the state to help them support their swing bed program and expand it, actually. And so, interestingly enough, but do we have folks that we've leveraged internally to, again, maybe share that knowledge, the expertise, to capture some additional volume within our swing bed, and to kind of help create and further define that care spectrum. Also, sometimes that ensuring that consistent understanding of skilled care services. We hear this a lot around not having an understanding of what type of patient meets skilled care. What can we skill a patient for? And oftentimes we hear, well, I thought it was just rehab, or we could only do, PT. We worked with a hospital in California, and they said, well, I thought you always had to have two rehab services. If they didn't need like speech and OT, then we could not swing them. So, again, making sure that we have that understanding of skilled care services really allows, and that education kind of spread wide, helps us really kind of articulate what we can and can't do for our organization. Providers, obviously, they play a key role in helping define our care spectrum. And so having them be a part, and I have to say, having a provider, whether it's the hospitalist involved in really getting that buy-in and that participation with a provider right at the beginning of helping define that care spectrum, and having their input around what's the types of patients do they believe are most appropriate for a swing bed admission. um, do they have any concerns around competencies of clinical staff? Is there any additional staff education that may be needed from their perspective? And really get their buy-in and support for really establishing this framework that's going to really help with that decision making for that accepted versus non-accepted patient. Of course, rehab, having that self-assessment on or inventory of what are the rehab services that we currently provide. Do we have variable hours of availability? Sometimes we know that we hear that, maybe if we have outpatient rehabs covering our inpatient unit and it's only certain times a day, or it's on an as needed basis, or or we have that staffing limitations that we hear, we can't always get to the hospital to provide services. We certainly want to understand, what do we have available, what's current capacity, and is there anything that we cannot take from a rehab perspective, and really having rehab be a part of this planning as well. You're probably thinking, oh, supplies and equipment. Why, why engage our materials management or folks? Well, certainly, having appropriate equipment can also impact admissions. Thinking about this maybe on the, certainly on the swing bed side, also very much so on the acute side. Making sure that we evaluate the age and condition, and if we have enough of some type of supply or equipment to be able to support any type of our admissions. Because one thing that we don't want to do is that we don't have the necessary equipment, or we don't have the supplies, or we're going to run out of the supplies, and that prevents an admission that we could have, certainly safely and adequately cared for in our hospital. And anything, we don't want to prevent admissions if we can help it, certainly. So making sure that we have necessary equipment. Maybe we have a need bariatric equipment and for our patients, and making sure that if we can't get it, can we rent it? Can the referring hospital send something, whether it's a supply maybe that we just need a refill on, and just hasn't come in? Can we work with our referral source to make that happen? Or if it can be rented somehow. Then we have pharmacy. Pharmacy is certainly a key factor here, similar to supplies and materials. Making sure that we have an appropriate medications for patients who are coming to our hospital. And again, similar to if we don't have that particular medication for that patient, can we get it? Is there after hours pharmacy resources that are available, so we're not delaying that admission at all, if that be the case? And understanding what we cannot do from a pharmaceutical standpoint that would prevent an admission. Some folks have mentioned that they do not take patients that are active on chemo. They don't have chemo drugs available in their pharmacy. They're not able to provide that service to that patient. So for that particular hospital, they know that is going to be a non-accepted patient for them. But maybe it is something that we should consider if your hospital does do infusions. Maybe they do have chemo, but maybe they don't have a specific type of chemo drug, or how that chemo is administered, things like that. So you go through that process of really taking a kind of a deeper dive into, yes, we maybe can, but maybe we can't over here. And I'm going to go through what that looks like in just a minute. And then lastly, rounding out the team for swing bed, that's going to really help define that care spectrum is the business office. And, certainly, I have heard from many folks that we often don't really involve the business office. Maybe we have a care manager or swing bed coordinator that does many of the business office functions prior to the admission of a patient. And, certainly we understand, some of the overlap that occurs. But if we can really involve the business office, understanding if there are barriers to payer sources that we have run into, getting, also understanding what that prior authorization or medical necessity requirements are for different payers, and having that business office be a part of that, because that too can certainly impact our admissions into our swing bed program. And don't get me started on, Medicare Advantage plans and the prior authorizations that are happening with swing beds, because I certainly hear that loud and clear from folks. And I wish I had a magic wand and certainly could fix that for you all. But, having them be very proactive in helping define what the needs and the process to help, kind of be efficient in helping that care spectrum and that process be more efficient. All right, and then one tool or activity, and you all have had access to the swing bed gap analysis for quite some time, which is the electronic version of basically a self-assessment of your swing bed program. And this is a great tool for you all to use to at least give you a baseline of some of the opportunity areas or some gaps within your swing bed program. And so a output of that gap analysis that you have access to on the Stroudwater portal is a opportunity matrix. And basically what it shows you is whether you have a match, a conflict, an opportunity, or NA. A match is that you've indicated that you have a specific clinical program, such as cardiac rehab, and you provide all the resources that support cardiac rehab. Or it may be a conflict. You've indicated, yes, you provide the clinical program, but no, you don't have all the resources to support it. And then on the opportunity areas is you've indicated that you don't provide cardiac rehab, but you do have all the resources. And so, opportunities are sort of that, needle in the haystack. We're really trying to look for those opportunity areas through this self-assessment, because it's an opportunity to say, oh, well, we do provide all these resources, but we've never, promoted or said or come out and say, hey, we provide this clinical program, for instance. So with that as background, certainly, and to continue to share what you do have access to as doing that analysis will really help, and that self-assessment will help as a tool, will help you build out your care spectrum or your patient framework. So just as an example, this particular hospital did their self-assessment, and you can, through their self-assessment, and I'm going to go over some key areas of their self-assessment. This one's specific to nutrition infection management. They had, certainly indicated that they provided some key nursing competencies around this particular clinical program. But one area that they indicated that they did not have expertise in was around PICC line insertion and maintenance. So they didn't have a nurse on a shift that could manage that. So, certainly self-reflecting, there may be opportunities to obtain some additional education for nursing staff on PICC line management. Because what if we did have a swing bed patient for that potential that maybe needed some infection management, needed a PICC line, needed, or had a PICC line and needed to have that maintained. Again, if we don't have that competency, that's not an admission to our swing bed program. Um, Equipment and supplies for this particular hospital, they had indicated that they actually had a service area. Again, so going back to understanding your patient population, they had high rates of obesity among their community. And you can see here from this self-assessment that bariatric equipment, so specifically with beds, they did not have. And they would actually transfer their patients out, or not accept a patient who was bariatric because they did not have that equipment. So there, comparing to what the need was in the community, does it make sense for this organization to either make some of those investments, consider the investments, or find a way to get those equipment needs to support that patient population, for any of their rehab needs or skilled care needs? Sorry about that. This here, talking a little bit about education. So not only do we talk within this self-assessment around various clinical programs, but there's also some kind of operational components of a swing bed program that we should be doing that is going to really help aid in just program development and in program improvement as well. So this particular hospital, they had indicated no, they don't have any nursing trained in post-surgical education and management. They likely did not have, a surgical program there. So we, had some of that lack of education on post-surgical education. They also lacked the use of a stoplight form, which we know is a great tool to help for our patients for certain disease categories, and to help them self-manage their diseases. And then also, not all staff were trained in the care of a patient with a history of substance abuse. So really, certainly there's some education opportunities and training for their nursing staff, whether that is around a specific patient population, substance abuse or post-surgical patients, and even helping to kind of educate them on a certain tool like the stoplight form to really kind of continue to help and support their program and their patients as well. So certainly some opportunities around staff and patient education. And lastly, on one of the key areas that we focused on their self-assessment was, as I mentioned, more on the operations of their program. This particular hospital, they did not have a timely process for their referrals, and so they, certainly something that they could be improving on if they were to define that care spectrum, that referral process, or that decision-making process. And then also post-discharge follow-up phone calls. They were not doing 30 days after discharge from their swing bed program. Certainly an opportunity to add that. And those are sometimes these kind of key operational parts of a swing bed program could be really easy to implement, and really continue to support your swing bed program. So with that also, and just as a reminder, you do still have access to developing the marketing flyer that is also part of the swing bed gap analysis. So whatever you have inputted on that swing bed gap analysis will also come out and be created into this marketing flyer. This is also really key when you think about it. If we have defined our care spectrum, the patients that we accept into our program, what is that? How, we should be leveraging that and communicating that to our referral sources. In addition to some of the patients that we don't accept, because if they have a better understanding about what we can do and the types of patients that we serve in our swing bed program, they're going to, it's going to help with their decision making, that, they know that Stroudwater Hospital is serves our community or our county, and they have expertise in PICC line insertion and maintenance. Hey, you know, we've got a patient that has a PICC line. We're going to send them there. Maybe we do um, short-term dialysis in our for our swing bed patients. We have those expertise, that capabilities. Great, my patient's on dialysis. I'm going to be able to send them to their swing bed program for skilled care. So again, having and utilizing this care spectrum development and making sure that we get that information out to our referral sources as well is really, really useful and beneficial. So you're probably saying, okay, great. So we've figured out what we're talking about as of a care spectrum and what that means. And we have kind of self-assessed our market, our patient population. We've leveraged our interdisciplinary team. Each of our team members have kind of key pieces on how we help with the development of our care spectrum. We've inputted our data into the swing bed gap analysis. Well, now what? I'm going to share now we take that information and we start to really shape that framework, that care spectrum. And it sort of looks like very elementary, but it sort of starts out looking like this. And you have almost like the types of swing bed patients that in a yes column and in a no column. Yes, we always accept this type of patient. No, we will not accept this type of patient, or we can't accept this type of patient. It's not that we don't want to, right? We just are not able to at our organization. And then you have this gray area. This gray area is, if the patient is, is can self-manage their medications and only needs rehab for 7 days, yes, we'll take that. But if the patient can't manage this, has to be in for this, has this other kind of chronic condition that we cannot support, no, we cannot. So it's looking at that gray area and then again doing some self-assessment and start to move those gray area patients into a yes or a no. Although some of those gray area patients may just come down to a provider decision making, and then really not be part of that care spectrum as well. We do have some organizations that they'll just work on defining these are the patients that we do not accept into our swing bed program, and just make that known to their organization, to their referral sources. And oftentimes that might be the easier way to go. But again, it's very similar process on how you get to defining the type of patient that we don't or are not able to accept into our swing bed program. So I have a few examples of what some hospitals have done on the acute side. Again, very similar to what you can be doing from a swing bed side as well. This particular hospital actually just looked at cardiac patients. And then you can see for their 4 kind of disease, cardiac diseases, chest pain, CHF, AFib, and syncope, you can see, from a 1, 2, 3, 4, 5 level of acuity, or in some cases 1 to 3, what they ended up doing with that patient. So if a patient had chest pain, they were low risk, heart score less than 4, pain free, and negative troponin times 2, they were discharged home with a cardiac follow-up. And so they started to again take cardiac patients and group them into better clinical decision making and pathways for particular types of patients. Very similar to, we could do a, hip fracture, and then we can say we would accept based on this, not accept based on this. Again, looking at those yeses and those nos as well. And they were able to also look through and help kind of minimize the gray area, if you will. All right. And for that particular hospital, they really wanted to focus on they were experiencing a lot of declines in their admissions. And so they came away with that care spectrum there on their cardiac patients as a way to uh, create that standardized approach for acute admissions. And that was their standardization, that taking it into those bite-sized pieces to, again, and they saw an increase in their ED admissions, and really were able to focus on their needs on the cardiac side by developing their care spectrum. Um, this particular hospital here, as an example, they looked and focused really just on better understanding their transfers, and so they did a whole transfer audit. And what they were able to find is that out of all of their ED transfers, one a lot of their transfers were actually going out of state. So they had they were within a health system. Their main hospital was in a whole other state. So their transfers were literally leaving the state. And then what they also found out was that they had identified 10 potentially avoidable transfers, so PATs. And so those were the potentially avoidable transfers were actually patients that they thought that they probably shouldn't have transferred and should have been kept here at their hospital for possible admissions. And so of those, whittled them down, of those potentially avoidable transfers, what is it that we could have that should have been a yes automatically? What was maybe the barrier? What was the gap? Was it just on provider decision making? What was it? So they, whittled it down to a manageable number to really kind of do that deeper dive on what those needs were, what those gaps were in their service delivery. So next time it would be maybe an automatic yes, maybe a potential admission versus a potentially avoidable transfer. For that particular hospital, they did, after really evaluating their transfers and their audit of their transfers, they did do some work on developing their spectrum of care. Since their implementation of that, they've decreased their ED transfers. They have seen an increase in their inpatient admissions. They did some kind of key operational items where they realized that they needed some additional support on the admission side. So they added a telehospitalist program. They had some needs around cardiology. So they increased their echocardiology tech coverage. And they also had some equipment needs and reduced a nuclear camera there. So really, opportunity out there for really coming together, leveraging your interdisciplinary team and really leveraging them to really define that yes and no. Maybe it is just focusing on the no, or and it's really, more work has to be done in that gray area. But again, with the tools of the gap analysis and some of the conversations that you'll have amongst your interdisciplinary team will really help start to help you define that patient care spectrum for your swing bed program. And so I think that's it. I do have some time for any type of questions. but certainly really encourage you. You all still have access to that swing bed gap analysis within the Stroudwater Analytics portal. And so that also can be updated too. So if you haven't gone in there in a while, maybe it's an opportunity to just go in and do a refresh. Maybe you have had some turnover, maybe you have some new staff members, and just do that self-assessment to, and then utilize that information to really help understand where there is a gaps, or maybe there isn't gaps, and but we now what we can do is really define our care spectrum and share that information. Share that with our referral sources and our team members to really help improve our swing bed program. So, time for questions. Again, as Laura mentioned, certainly you can take yourself off of mute, or you can drop any questions in the chat. Slide deck will be made available and the recording as well.
Lindsay, I'm not seeing anything come through the chat just yet. But thank you. This has been a lot of really great information. And as Lindsay mentioned, we will be putting this recording on YouTube, as well as making these slides available with the recording link. So one last glance, one last run through. I don't believe we have any questions. If you guys run into questions after this or watching the recording, please feel free to reach out. And Lindsay, thank you for your time today.
You're welcome. Have a great day, everyone. Thanks.